Hello, I'm Peter Suzuki, publisher of Check Rare. Today we're going to be talking with Dr. Raymond Wang, biochemical and clinical geneticist at Children's Hospital of Orange County, based in Southern California. Today, Dr. Wang will be talking about a lysosomal storage disease called MPS. Dr. Wang, to begin our conversation, can you tell us a little bit about yourself, about your practice, and about this rare disease?
So I'm Dr. Raymond Wang. I am a biochemical and clinical geneticist. I am based out of the Children's Hospital of Orange County in Southern California. I supervise a multidisciplinary lysosomal storage disorder program, which includes clinical care, clinical research such as clinical trials, and translational research, i.e. bench work, all pertaining to these lysosomal storage disorders, which includes conditions such as MPS and GM1 gangliosidosis. What else? I've been in practice at CHOC since 2007. So I've been here at Children's Hospital of Orange County for 15 years. Watched the program grow from a small contingent of patients to now, more than 100 odd patients with various different forms of lysosomal storage disorders. And I think, a little bit of maybe background on what got me interested and what had me choose the field. I think, in the beginning of the 2000s, I was a trainee, and I was going to go into clinical genetics because, that was an area that has interested me since college. But I think around that time, there were announcements and FDA approvals regarding alpha-L-iduronidase for MPS type 1 and another enzyme called Fabrazyme for a different lysosomal condition called Fabry disease. And I thought it was pretty fascinating, exciting that, there are these conditions that I'd read about in textbooks, and the textbook said, oh, there's no treatment for these conditions. And so to then discover that, there were people working on clinical trials and that suddenly there are medications available for these previously untreatable conditions. And, now we know that, lifespan is extending, and, children who weren't expected to survive are now surviving into adulthood. And so this really is a field, biochemical genetics or metabolic disorders, whatever you want to call it, is really in a field of, in a frontier where there might not be treatments now, but there are definitely people who are committed to developing therapies for, what we call incurable or currently incurable conditions where there's, nothing out there, that there are people working to fill that gap. And I think, that's a bit of a background on my motivation for wanting to be a part of this. You go into medicine to help people, to help children. And in my case, I'm also pediatrics trained. And I think there's just something that's inherently not right when you sit down with a family and you have to give them a terrible diagnosis, and then the next shoe that drops is, and there's nothing available for your child. And I don't know, it just doesn't sit very well with me. And so, going into this field and then becoming, a part of clinical trials really helps me to maybe stand in that gap between we've got nothing and we've got something.
Yeah. We're talking about lysosomal storage diseases today, specifically MPS I. Can you tell us how many people have maybe lysosomal storage diseases, but specifically MPS I? How many patients in the United States?
Yeah, so it is a rare disease. I believe the US definition of rare disease is, and correct me if I'm wrong because I'm using the top of my, is less than 200,000 people affected. And I'm pretty sure we're far less than that. Even after states have been doing newborn screening for MPS I, the estimated frequency, of MPS I in births is still probably about, 0.1 per million births. So probably no more than, what is that? The state of California has roughly 500,000 births per year. So I can definitely say for California, that's no more than 5 babies born statewide. Don't really recall what the birth rate is for the entire country, but you can extrapolate from there. It probably isn't more than several hundred patients.
You had said when you started down working within lysosomal storage diseases, there weren't many treatments available. How are MPS I patients currently treated?
Sure. So there are 2 methods of treatment. One I alluded to previously is called alpha-L-iduronidase. It's basically a synthetic version of the enzyme that patients with MPS I are missing. It's called, the official name is alpha-L-iduronidase. And the enzyme basically breaks down a form of sugar. It's not table sugar, it's not used for sweetening, it's actually highly modified and used for connective tissue and cartilage, and it's found in the brain as well. And when you have MPS I, you have a deficiency of alpha-L-iduronidase, and so the sugars that these chemicals are a part of, they're called glycosaminoglycans or GAGs. They can't get broken down, they can't get recycled, and so as a result, they build up inside the body. So liver, spleen, joints, connective tissue, brain, that accumulates in all of these different tissues. And the more of that you build up, the sicker those tissues get. So the other treatment is stem cell transplant, hematopoietic stem cell transplant. It's also known as a bone marrow transplant or umbilical cord stem cell transplant. And that is used not because there's something wrong with an MPS I patient's bone marrow. Their blood cells work completely fine, with the exception of not having any iduronidase. The reason why a stem cell transplant is done is mainly because of the neurologic manifestations of MPS type 1. So as these glycosaminoglycans or GAGs build up within the brain cells and the connective tissue of the brain, the function of the brain starts to decline, as you can imagine how a cell isn't working too well when it's full of, waste material. And so without treatment, these MPS I children, they were called Hurler syndrome or all sorts of different names, but it's describing the same condition. Patients with a severe version of MPS I called Hurler syndrome, their development talking, walking, running, et cetera, would actually start to slow down and plateau. And as the amount of waste product accumulates in the brain, they would actually start to lose milestones and eventually become, sadly, unable to walk, unable to communicate, unable to eat on their own. And it's just really a tragic sort of a set of circumstances. So the idea of stem cell transplant is that while most of the stem cells go back to the bone marrow, some of the stem cells actually cross this barrier called the blood-brain barrier and go into the brain, where it becomes the immune system of the brain. Well, the neat thing about these cells, these transplanted stem cells, is they also make a little bit of iduronidase. And so the enzyme that leaks out of the stem cells goes to the surrounding neurons and connective tissue and helps to rescue, these cells' deficiency. And so definitely stem cell transplant has been used as a therapy for severe Hurler syndrome for probably upwards of 2+ decades. And definitely it helps to, prevent this like really tragic decline in neurodevelopment that's seen in the Hurler patients. Of course, the stem cells of the bone marrow also make enzyme, which then goes to all the rest of the tissues of the body, liver, spleen, et cetera, et cetera. So those are currently the two approved therapies for MPS type 1.
Yeah, and so we're going to be talking about your research in gene therapy, but for these patients, before we jump into that, can you just talk a little bit about gene therapy? What
Sure.
is it, and why specifically for genetic diseases, genetic rare diseases, is gene therapy mostly used for?
Sure. So we always saw enzyme replacement therapy. So the best way to analogize enzyme replacement therapy is that you have, a car that has a gas tank that you need to go. And if you have an inherited disease, maybe MPS, maybe a lysosomal, maybe, any other metabolic disorder, your car is running on empty. It doesn't have what it needs to go. In this case, it would be iduronidase, or the enzyme. The principle behind enzyme replacement therapy is you're basically taking exogenous synthetic enzyme, and then you're like fueling up your car. And your car is able to run for a certain period of time, but then it runs empty again. And so you need to fill up again. And so enzyme replacement therapy is an ongoing, otherwise indefinite, children have to get an IV or have a central line placed here, and then have an infusion every week because, the enzyme lasts for less than a week in the body. So you have to keep, filling your tank up over and over again. And, at about 4 or 5 hours per infusion, you imagine being to an IV for that period of time every week. It can get disruptive with school. You just lose freedom for that period of time, but you have to do it because, without it, the disease is going to continue to progress. Moving on to stem cell transplant, it's not without its risks. In order to make room for the donor's stem cells, you have to undergo very, very high dose chemotherapy to essentially eliminate your existing immune system, right? So during the period of time that the transplant starts till the cells start to grow and you make new white blood cells and red cells and platelets, your body doesn't have an immune system, so you're at risk for infections. You may need blood transfusions, platelet transfusions, because again, your body can't make its own cells. There's a risk of your transplant not taking, or what we call graft rejection. There are a whole host of other things where the transplanted immune system actually starts to attack the recipients, called graft versus host disease. So it's not a walk in the park. There are risks involved, but given that there aren't any other alternatives, that's really, families really have no other choice. So circling back to your original question, which was, why gene therapy and clinical trials and that kind of thing. Gene therapy is basically, it's also called gene replacement therapy. It's essentially equipping the body cells with the ability to make normal functional enzyme on their own. So rather than having to, have your car get filled up every week with an infusion, the ideal for gene therapy is that you get one treatment. It's essentially a little carrier. So currently what's being used is something called adeno-associated virus. It's essentially a virus that has its infective DNA ripped out. And so all that you have is a shell, which does its job of finding a cell and fusing with it and delivering the cargo inside. Well, in this case, instead of viral DNA, you are putting the gene for iduronidase, or the gene for, GM1 gangliosidosis or MPS II, or you name it, whatever genetic condition there is, you put the gene that's missing in these patients and encapsulate it in this carrier. You deliver it hopefully one time, and then these viruses go throughout the body and they find the cells that they're supposed to fuse with. So, brain cells, liver cells, whatever. And then you now equip the cells of your body to make the enzyme that you're missing. It would be fantastic, if then your cells are able to make this enzyme forever and ever, and then you don't need enzyme replacement therapy. And the risk, as far as we can tell, is not as severe or significant as that of a stem cell transplant. So that's the promise. At the moment, everything's still in a clinical trial for many, many conditions. So whether or not it is a permanent solution is unknown. That's what these clinical trials are being done for, is to see, A, do these patients make enzyme? Are there developmental issues being addressed? And, does it last forever? That would be the hope and the ideal for this therapy.
And so you have experience with gene therapy and MPS I patients. Can you tell us about it and tell us about the trial that you're involved with?
Sure. So, I think we wanted to participate in this clinical trial. The gene therapy is called RGX-111. And it's essentially, as we mentioned, the iduronidase gene that's surrounded by a virus capsule called AAV9, or adeno-associated virus type 9. It is delivered via an injection into the junction here between the spine and the skull. Seems like a big deal, right? You're like, oof, like that's pretty delicate, and definitely I don't want to underestimate the challenges there. However, the reason why that site was chosen was that it's the site that's closest to both spine and the brain. You want to bypass this blood-brain barrier and deliver this therapy, directly to the site of the disease of Hurler's or severe MPS I, which is, your central nervous system. We have a really amazing doctor called an interventional radiologist. His name is Dr. Beydoun, and his job is essentially to get into really, really difficult to reach places in as safe of a manner as possible. And so what is done is that, these patients are obviously put under anesthesia, but it is what's called a CT guided intracisternal procedure. So, and obviously there are very high stakes here. The spinal cord is very, very close, to brain, and there's not a lot of room. So you use a CT scanner, and it's not just to take pictures, but it's pretty amazing. So Dr. Beydoun will put the needle in a very short distance, just barely breaking the skin. He'll take a scan, and the CT scanner can actually inform him where he is. If you keep going, where are you going to end up? And then allow you to visualize where he needs to go. And so every few millimeters, he'll advance, take a new picture, readjust the direction. And so it's a procedure of very high precision, as it has to be, given, the risks of, permanent injury if you actually end up touching the spinal cord. So, and that's the best way to provide these RGX-111 gene therapy into the central nervous system. We've treated 4 patients here at Children's Hospital of Orange County. There are patients that have been treated at Children's Hospital of Philadelphia as well as in Brazil, but we were the first to treat. We've treated the most patients so far.
And what is your experience? How are these patients doing once they receive this therapy, and how does that compare with traditional treatments that you talked about earlier?
Sure. That's probably the most exciting part of the study. Of course, everything is very preliminary, but we are able to present some of the interim results a few months ago at a scientific meeting in San Diego called the World Symposium. Our longest treated patient has been treated for about 2.5 years now. This patient was about 20 months old when we treated them. So they were at a stage when, what we call the natural history, so predicted by observing many, many other Hurler patients in the past. That patient was still on the way up in terms of, development. In the past 2.5 years, we've been tracking this patient's development with, neurocognitive testing to see how they're tracking in terms of, gross motor skills, cognitive skills, speech, et cetera, et cetera. And it was really exciting when we saw the cognitive testing, which showed that that patient has continued to be in normal range. Now the patient is more than 5 years old, I think. And that is beyond the age that severe MPS I patients are expected to start declining. So we're actually seeing a separation, if you will, of our treated patient from what we call the natural history. So whereas untreated patients, natural history-wise, are expected to be declining at age 5, this patient continues to progress in their cognitive developmental milestones. So I think, that's like proof positive that the therapy is working. The conclusions are still pretty preliminary for the other, 3 patients that we've treated, indeed the whole phase 1/2 study, but all the indicators are pointing, in a similar direction for the other treated patients, that it's making a difference.
Sure, it sounds super exciting, and anytime a rare disease gets a treatment like you spoke about earlier, everyone's excited because these patients had nowhere to go previously. How do you, what's next? And it's easy to say you finished a clinical trial, but I'm sure this whole patient population is aware that this treatment is going on and is probably banging on your door and trying to get treatment. How do you manage that within a rare disease, wanting to help these patients, but also balancing the act that you have to fulfill a clinical trial to get a drug approved or gene therapy approved?
Definitely. So this is a phase 1/2 study. So for those listeners who might not be, well versed in sort of FDA speak, there are essentially several steps that are required to get to the stage of an FDA approval. Phase 1 studies are typically looking at safety. So, we want to first do no harm. So is our therapy actually causing more issues, adverse effects, side effects, what have you? And often for rare diseases, the first 2 phases get combined, because phase 2 is also looking at dosage and various other things. So because it's a rare disease, the initial study was a phase 1 looking at safety, and phase 2 looking at various different dosages. It's still in progress. So after these, the study has enrolled its requisite 5 patients. There's a pause to sort of look at this thing called interim efficacy. It's like you sort of peek and see, how's the data looking? Are there any, side effect signals that are concerning? And if things look, positive, then there's an additional enrollment. So although 5 patients have been enrolled, there are an additional 6 patients that are, approved to get into the study. That hasn't started yet, but I think we're getting there. And if anyone listening is interested, it's National Clinical Trials number 035-80083. The study is called RGX-111 Gene Therapy in Patients with MPS I. After that, then you do your important phase 3 study. Phase 3 is where it's kind of the make it or break it. You enroll a larger number of patients, and you rigorously, not that phase 1/2 isn't rigorous, but the specific focus isn't on dosage or that anymore. It's really, do the patients that are treated get better compared to either untreated patients or patients who have received stem cell transplants or that kind of thing. So I know that's in the future. That hasn't been opened up yet, but once the data from that comes in, then there's a overall review of all the data and a consideration, possibly for approval. And the more treatment options for, families, patients with rare diseases, the better. And I think this really, we've been talking mostly about MPS I, but there are a host of other lysosomal storage disorders, rare diseases with neurologic involvement that are just waiting in the wings.
And I guess are there learnings from this clinical trial and this specific gene therapy that can be used across other MPSs, other lysosomal storage disorders?
That's a good question. So I think that, this is the first gene therapy clinical trial for MPS I. It's also the first gene therapy clinical trial for any MPS. So I think, in terms of learning about, say, how's the method of delivery, I'm happy to say that this, what's called an intracisternal injection has actually been, quite safe and well tolerated. The patients are awakened from anesthesia several hours after the procedure, and they can start eating, and they go home within 24, 48 hours after the procedure, right? So the recovery period is much, much, much shorter compared to, say, a stem cell transplant. We're learning about sort of, how there are all sorts of medications that have to be administered to prevent the body from rejecting the gene therapy. And so we're learning about, what the proper regimen of immunosuppressive medication are required. You can't just, give the gene therapy and walk away. You do have to make sure the body doesn't reject it. Other things, just long term, like how is this going to be developmentally? Is it going to compare with stem cell transplant? Is it going to be better? Is it going to be equivalent? All those things are still up in the air, but being one of the first gene therapy studies, it will sort of pave the path for future studies.
I think that's a good jumping off spot or finishing spot. I appreciate your time today. I thought we covered a lot. I thought this told a nice story all the way through. And again, always appreciate your time, your research, and your help for these patients.
Definitely. Thank you for having me. And I hope this podcast helps to not just raise awareness of rare diseases, but also let people know that there are folks who are very committed to making sure that there's hope and an answer and a possibility for a therapy when there never was before.
I agree. Well, thank you again for your time, and hopefully we can meet again soon.
Would love to do that. Thanks, Peter.
Okay. Take care, doctor.